Apologize for my lateness. The meeting will come to order. Sheila, can you call the roll, please?
Ms. Bernard, Mr. Furman,
Present.
Dr. Hans. Dr. Hans did notify me that she'd be a little late. Mr. Landsman,
Here.
Ms. Namie Dyer, here. Mr. Cowan,
Here.
Ms. Root, here. Dr. Cobb,
Here.
Mr. Torres, Ms. Newman.
Present. Thank you. Next is our first opportunity for public comment. Is there anyone that would like to give public comment today?
There is no public comment in the online chat. However, we do have someone present.
Good afternoon, sir. Could you please give us your name and your locale?
Hi, my name is John Young from Rochester Hills. I was appointed Thursday night by the County Commission. I just wanted to stop by and informally meet everybody, and hopefully the rest of the paperwork goes through at the county, and we'll be joining you guys officially soon. I have two sons in the autism spectrum, and I used to work in healthcare before I came into Ochn University. I worked with Sarah Guadalupe. Sarah has told me a lot about the proceedings that you have all done. So I see it at work, and I literally, when I leave here, I will see the services at home. So looking forward to joining the group. So I just wanted to stop by and say hello to everybody.
Hello, welcome.
Thank you.
We'll see you again.
Yep, you will.
Is there anyone else that would like to make public comment today? Seeing and hearing none? Okay. Now, I need approval of the agenda.
I make a motion to approve the agenda.
It's been moved by Adam. And do I have a second, please?
Support.
Supported by Mr. Cowan. Oh, I'm sorry. Do we need a roll call for this? Okay. All in favor?
Aye.
Aye. Any opposed? Thank you so much. Now I'll turn this portion of the meeting over to Remy.
Good afternoon, everybody. We have a couple contractual obligations to review. First is Mr. Franklin is going to just give us some updates about the Thunder Mop contract, and then the Business Ops Committee will vote whether or not to move this to the board meeting next week for a full board approval.
Good morning, or good afternoon, I'm sorry. This contract is for approval item for the Thunder Mop Diversified Vendor. The contract is for a 2-year janitorial services. The proposed contract amount was, total contract is for $1,163,933, and we've been contracting with them since fiscal year 18. This is for the scope of work for Ochn janitorial services for both locations. It includes RCC building as well as the 5500 Corporate Drive location. This contract was initiated on January the 15th. We brought it before the board for your approval. We are requesting for an extension at this time of that contract. We tried to apply different, we tried to contract with some of the next contractors in line on the RFP, and we end up going with the original current contractor, which is Thunder Mop, and we want to extend their contract this time. I think the dollar amount annually is for $267,000, 2-year contract. That also includes, that's not the total amount, it includes the not-to-exceed amount that we're contracting for. We have added some other services that may occur during the course of the contract, such as COVID cleaning or carpet cleaning, which we have done in the past. And so the original contract amount was $225, and we added additional cushion for other services that may be needed during the course of the contract. So we're seeking approval for this contract.
Okay, we're going to open it up to questions. Mr. Lansman?
Yes, thank you. So we've been using Thunder Mop for a while. We just moved to a month by month for a couple of months now, right?
That's correct.
So will we also need to have a motion to discontinue the other approved contract that we did a few months ago? Do you
Well,
think?
we already discontinued that, and we were going down the next bidder in processing the RFP process, and no one met the criteria, and they couldn't meet their obligation. So after trying 2 or 3 different vendors on the RFP list next in line, we decided to go with Thunder Mop.
Okay, so then the other vendor that couldn't meet the needs, had they been officially notified they've been disqualified? And they're no longer a selected?
And so that's what we're doing. We're doing we're extending the contract and looking at possibly RFPing it at a later time.
Okay. Thanks, Ben.
Mr. Lansman, are you talking about the, what was the group called? Italian, that group? Because I think that was already decided during the last board meeting that we ended that contract.
That's correct. We
We did a temporary extension with Thunder Mop, and now you're looking to do a full extension for the year?
That's correct, yes.
I knew that we had done that. I just wasn't sure if we had to do anything else from either a board or from an organizational with the other housekeeping company. That's all.
Yeah, we did our due diligence. We made sure we looked at the next bidder that was the highest scoring and ranking, and we did a process of elimination, and we ended up with Thunder Mop.
All right. Well, thanks.
Ms. Root?
Can you explain the cost of living increase option that was noted in our board documents?
That was right now. I think that was the problem. A lot of the other vendors were having. They couldn't get workers to come and work for them. They couldn't hire the people in time due to a lot of people were receiving unemployment at the time. They were getting offers that were greater than what they could offer at the time, and that was the problem with the other contractors being able to meet the obligation. When we tried to reach out to them, some of them wanted to increase their contract bid amount that they bidded it on the RFP, just to meet the market conditions of hiring people. And so that's why we told Thunder Mop, we look at it and say, okay, after a year, you can come and let us know if there's market conditions dictate that you have to pay people more, and we'll look at it, but it's no guarantee.
So if we did pay, or if they were paid more, is that cost included in this $1 million number?
Well, we do have cushion built into the contract. It's already included in there.
Okay, thank you.
Any other questions or comments from board members? Okay, seeing none. Business Ops Committee, we just need a motion to move this to the board meeting for approval at the board meeting.
I motion to approve the Thunder Mop contract and move it to the board meeting.
Okay, thank you, Adam. Do we have a second?
Support.
Seconded by Mr. Cowan. Does this require a roll call vote from the Business Ops?
Can I just clarify the motion, though?
Yes.
The motion to move to the board meeting. So can we clarify it's for recommendation for approval to the board meeting?
Yes.
Thank
A
you.
recommendation for approval for the board meeting.
At the January, or
At the
February
general board
15th
meeting.
board meeting.
Okay, all in favor?
Aye.
Any opposed? Okay,
Thank you.
Thank you, Mr. Franklin. And next, we have Ms. Ali to discuss the CMHSP contract amendment.
Good evening. Kalana Ali, Chief Legal Officer for OCHN. Today before you, I have the CMHSP contract for your review and approval. The recent amendment was an increase to our actual funding in the amount of $486,625. There were no other substantive changes to the agreement at this time. Is there any questions? I will entertain any questions if there are any.
I don't see any questions. Okay. So, do we have a motion or a recommendation to move this approval to the general board meeting on the 15th?
I move to recommend to approve the CMHSP contract and move it for potential approval to the board meeting next week.
Thank you, Adam. Do I have a second? Anybody in business ops?
Support.
Thank you, Mr. Collin. All in favor?
Aye.
Okay. Any opposed? Okay. Thank you. And I believe that is it for business ops. So we will move back to Ms. Newman for policy management.
Thank you. Next up, we have the QAPIP report with Marquita Massey.
Ms. Dyer, Naomi Dyer, can I just make sure that everybody voted in favor of the PHP? I was typing.
Yes,
Okay.
yes.
So we got the committee.
Yes, it was Adam, Mr. Collin, and myself. I think we are the only business ops
Okay,
members
thank
here.
you.
Yep.
Mm-mm.
Okay, can you hear me? Good evening, everyone. I'm Marquita Massey. I'm the Director of Quality and Regulatory Compliance here at OCHN. I have not met some of you in person, so it's good to meet you. I'm here this evening with our Clinical Director, Adam Hamilton, and we are going to give you an overview of our Quality Assessment Performance Improvement Program, the year-end report. And at the board meeting next week, we'll be requesting approval on the QAPIP. The QAPIP is an activity that we are required to do annually, and we are required to present it to the board and seek board approval. Can move to the next slide, please. In terms of why we do the QAPIP, it's a requirement in our contract with the state, which is handed down to the state from CMS. It has the minimum assurances that individuals and that PHPs must meet. It has all the minimum components that a quality improvement program must display. In terms of what is required from the board is required to render oversight to the QAPIP operations. I mentioned that it includes the minimum components that are required to be in a QAPIP. OCHN actually exceeds the requirements that are required to be in a QAPIP in terms of our involvement of all of our quality committees, the committees that our medical director participates in, and activity from individuals served. Can you move to the next slide, please? So I mentioned how the board approves our QAPIP. That happens every year. The documents that you received in your board packet are pretty heavy documents. But it's important to note that throughout the year, staff provide presentations and updates to the board on the content of the QAPIP. So for the most part, all the activity that is in this aggregated report, you've received information on throughout the year. I just want to run through a couple of presentations where we've talked about QAPIP activity. In January of 2021, we presented the fiscal year 21 QAPIP and the year-end report for fiscal year 20. In February, there was a presentation from our clinical team on activity, where we also spoke about integrated health care and the behavioral health homes. In March of 21, we had a presentation on the Sentinel Event Review Committee. In April of 21, we had the quarterly update from the provider network team highlighting self-determination, organizational credentialing, and contracting areas. In May of 21, we had the quarterly report from QM where we highlighted performance indicators, our NCQA status, and then activity pertaining to practitioner credentialing. In July of 2021, there was a presentation to the board on self-determination, and in November of 21, there was a presentation on member experience and member satisfaction. Move on to the next slide. Minimum requirements that must be met. The QAPIP is the foundation of our QI program. It provides assurances to persons served and to the state on the components of what you are addressing in your quality program. I mentioned that our processes that we have here in place at Ochn exceed the minimum requirements that are outlined in our contract from the state, so that's something that we're proud of. Can move on to the next slide, please. In terms of policy and fiscal implications, it's supported by federal regulations. It's required by the state. It's also required that we have this in place by NCQA. And on an annual basis, we are reviewed by the external quality review organization that the department contracts with to ensure that all the components of the QAPIP are met. This slide depicts the 4 sections that NCQA requires that your quality program have in place that you must meet. So the quality of clinical care, safety of clinical care, quality of services, and member experience. So our QAPIP, our quality committees tie to each of these areas. This slide here is a depiction of all of our quality committees, and you can see that all of our quality committees report up to our quality council, all of which are summarized in the aggregate report that's in our QAPIP, and then the final approving body is our board. If you were to refer to page 2, the table of contents and the QAPIP year-end report, you would be able to see how all of the quality committees align to each of those 4 areas. So in terms of quality and safety of clinical care, our Improving Practices Leadership Team, our Integrated Healthcare Committee, our CERC, and our UMC speak to those areas. In terms of quality of services, we have our Credentialing Committee, and for member experiences, we have our CEEC, Citizens Education and Evaluation Committee, our Citizens, I can't remember what the A stands for. Advisory, drew a blank. Citizens Advisory Committee and the Recipient Rights Advisory Committee. So those are examples of how all of our quality committees tie into those 4 areas that are required by NCQA. So what our intent here that we want to accomplish is to provide the board with an overview of accomplishments for our QAPIP program for the year, talk a little bit about the barriers that prevented the goals for certain areas from being met, interventions that have been planned and made, and then plans for the coming fiscal year, and also to make it known where persons served in the public can obtain a copy of the QAPIP that is available on our website. And that slide, we do need to update a bit. Our website is undergoing a couple of revampings and revisions, so the path to get to that is a little different right now, so we'll publish that. Move on to the next slide. So here, we want to begin to talk about some of the highlights from each of the quality committees that tie into each of the areas. I'm going to speak about our Quality Improvement Council and also our performance improvement projects. There's a typo on the slide. It says performance improvement plans. It should say performance improvement projects. So in terms of our Quality Improvement Council, and that's also our risk committee, that's chaired by our medical director. The members of that committee would be our medical director, our chief nursing officer, our clinical director, myself, the director of the provider network team, the access director, and the SUD director. The purpose of that committee is to ensure that content is flowing up to the Quality Improvement Council that occurs throughout OCHN. The Quality Improvement Council reviews progress on our quality measures for the organization. They're looking at progress on our HEDIS rates, looking to see where there might be interventions and changes that we can make. The committee also receives reports on our coordination of care projects that we are required to do for NCQA. We are currently looking at coordination of care across our network and also with our medical providers that we interact with. So the measures that we're looking at pertain to our HEDIS measure, looking at medication adherence for people with depression at 184 days, at 84 days and 180 days. It's important to note that our performance for the 84 days was above the goal that we identified of 49% for 3 quarters in FY21, and then we fell a little bit below in the last quarter in 21, but that was very good progress. And then for the 180-day rate, we were above the goal for 1 quarter in the year, but slightly below in the others, but still above where we initially started out. In terms of our performance improvement projects, our contract with the state requires that we have at minimum 2 performance improvement projects. We have multiple projects that we've undertaken throughout the year, but the 2 formal ones that are reportable to the state in our contract pertains to diabetes screening for individuals with bipolar disorder and schizophrenia. At year-end, we were at a 77% performance rate, which is pretty close to our goal of 80%. Not quite at the target, but close. And it's a great improvement over our performance in fiscal year 20. So we continue to improve there. And then our other formal performance improvement project is pertaining to transitions of care for individuals that are transitioning from acute care to the community. We didn't see an increase in performance in fiscal year 21. The pandemic has had a tremendous impact on a lot of performance areas, and that's one area that we believe has been impacted from being able to show a significant increase in performance in that area. However, because it's an important area to focus on, we're going to continue to work in that area and focus intention on improving in that area. Some of our other performance improvement projects that we have pertain to report outs that we have to make to NCQA. So we are looking at improving access to care and also looking at improvement in our performance in regards to services and CAFIS scores. So at this point, I'm going to turn it over to Adam to speak on the remaining two items on that slide that we were just on.
Marquita, are you going to wait to the end for questions, or?
Whatever you prefer, it's fine.
Okay. Because we've gone on for a little time. I don't know if people have questions. I had a couple, at least one. On that QI committee structure, the MSAT group, where do they fall in here?
Which group?
MSAT.
MSET,
Mm-hmm.
Michigan Consumer Evaluation Team. That
Right.
would be under member services, but that's not a quality improvement committee. That
Okay.
that group provides us with satisfaction data. So they, they administer the surveys for us.
Okay.
So what's on that diagram are our formal quality improvement committees here at OCHN.
Okay, thank you. Are there any other questions from the board? Okay, thank you.
Okay, good evening. Thanks for having me tonight. I'm going to talk a little bit about our Improving Practices Leadership Team and some of the integrated healthcare initiatives that we're undertaking here. The IPLT is charged with ensuring that evidence-based and best practices are utilized across the OCHN system of care. The committee is, the IPLT is really led by the clinical practice team here at OCHN. Generally, I will facilitate that meeting. Our clinical supervisor and the clinical analysts help me with the running of that meeting. And the meeting is really focusing on practice delivery across the whole system. We have representation from across the provider network at that meeting. In fiscal year 21, the IPLT reviewed all of the OCHN clinical protocols. This is to ensure that they reflect our mission, vision, and values, and that they are in alignment with MDHHS guidelines, federal guidelines, generally reflect what research says is clinical best practice, and that they meet NCQA requirements where applicable. The use of evidence-based practices is also a common topic at that meeting. The clinical analysts at OCHN participate in many state-level work groups and collaboratives related to evidence-based practices. So we are often taking information that we are getting there and bringing it to this meeting to discuss and to support the provider network in continuing to administer those evidence-based practices in the manner that is most effective for individuals receiving services. The other things that we do there will involve using the opportunity to connect with the provider network. We elicit feedback about our clinical protocols. We convene a work group to review each protocol that we're going to revise. So we will request that the provider network have their staff volunteer to participate in those work groups, and then we bring the revised protocols back for review. And the review at the IPLT is part of the final approval process. Regarding integrated healthcare, this committee convenes quarterly. The OCHN nurse case managers are central to running this committee, and they look at a variety of integrated healthcare related things, including HEDIS measures and our performance relative to those HEDIS measures. Some of the things that they will do is discuss the interventions that are talked about at our medical directors advisory group and talk about the implementation of those interventions related to integrated healthcare and HEDIS measures in our system. They look at data and trends related to HEDIS measures and other integrated healthcare data that we're tracking. And they will also discuss and talk about other integrated healthcare initiatives that we're doing, such as complex case management. Regarding MSET, you know, one of the things that MSET was used for was to do some satisfaction surveys of the individuals who participated in complex case management, and then that data was brought back and discussed at the Integrated Healthcare Committee. Marquita, you want me just to go right into CIRC then?
Yes.
Okay, gotcha. The Sentinel Event Review Committee, or the CIRC, is responsible for reviewing all incidents that meet the definition of a critical event. And just for informational purposes, that would include any arrests, deaths, emergency medical treatment due to injuries or medication errors, hospitalizations due to injuries or medication errors. And in in fiscal year 21, the CIRC reviewed 713 critical incidents, and 10 of those were deemed to meet the definition to be considered a Sentinel event. And a Sentinel event is defined as any unexpected occurrence involving the death or serious injury or psychological injury or risk thereof to an individual receiving services. When the CIRC identifies an event as Sentinel, the provider is required to submit what's called a root cause analysis, or an RCA. And the intention of this is to help the providers identify factors that might have been causal in the occurrence of the event, and then develop an action plan and a process for measuring the implementation and the effectiveness of that action plan to prevent that occurrence from happening again. Occasionally, we have to send those back for revision. We expect that these are turned in with 30 days, and then the CIRC reviews and approves those. Some other activities that the CIRC is involved in is reviewing trends and data on a quarterly basis related to incident reports and risk events and critical incidents that the CIRC reviews. The providers, as part of their participation in OCHN's QI initiatives, have to submit QI plans, and there are some interventions identified in their QI plans to address risk events. So the CIRC will be involved in reviewing those as well and discussing those. The Medical Directors Advisory Group is chaired by our Chief Medical Officer and includes medical directors and other key medical staff from across the provider network. They focus on assuring that evidence-based standards and best practices are used by the OCHN provider network, and they assist in developing protocols and procedures to ensure that the quality of care and the use of those practices is present across the entire network. In fiscal year 21, they also were evaluating HEDIS measures. As I mentioned, they developed some of the interventions that were discussed in the Integrated Healthcare Committee. And many of these relate to the prescribing of medications or the monitoring of individuals who have had medications prescribed to them. This couple examples would include a HEDIS measure that looks at the adherence to antipsychotic medication, the adherence to antidepressant medication, et cetera. One of the things that the Integrated Healthcare team was working on here, and this involved guidance from the Medical Directors Advisory Group, was sending out monthly reports to the provider network regarding individuals who were prescribed multiple medications to assist in monitoring the safety of prescribing multiple medications. There are sometimes occurrences where an individual will maybe be receiving medications from multiple providers. So evaluating that to ensure that the prescribers within our system are aware of that and can address that safety issue as necessary.
Okay, and I'm going to speak on the last two bullets here, credentialing and privileging and home and community-based services status. Both of those fall up under the quality of service umbrella. In terms of credentialing and privileging, we have really two tracks. We have organizational credentialing that is handled by our provider network team. That pertains to ensuring that anybody that we contract with, that they're in good standing, they have a valid license, they're not sanctioned, and that's something I know that the provider network team will cover, so I'm not going to speak on that. But I am going to just provide you with a little bit of an overview on practitioner credentialing. So that's another important area that is a key focus area for NCQA. It's important that we know that the practitioners providing services in the network, it's important that we know that they are qualified, that they have been cleared on the National Practitioner Data Bank, that they completed proper education, and that they are not sanctioned, meaning they're not excluded from participating in any federal payment program. So in terms of how we ensure how that happens here at OCHN, we, of course, we audit our providers. Last year, we audited our provider network twice in the year to ensure that the standards were met. We meet quarterly with our network leads in terms of the staff persons that are responsible for credentialing. At our internal OCHN credentialing committee meeting, which is also chaired by our medical director, Dr. Posios, we review the clean files that have been presented to ensure that they're good to go, and if they're approved, and if there any clean file that is presented is reviewed, any questions or deliberations that need to be asked or entertained at that time, and if all is well, staff file is approved. That ensures that we have accurate information in our directory. We also reviewed provider policies in terms of credentialing to ensure that they align with NCQA. And also this year, starting at the beginning of this fiscal year, upon board approval of the MedPercent contract, we began onboarding MedPercent for credentialing of our SUD and ABA providers. We expect to be able to roll out that probably in the next several weeks for those providers. In terms of HCBS, there is a lot of activity going on. The federal compliance date for being in compliance with the HCBS rules is March of 23. So at this time, we are working with our providers to ensure that all providers that provide HCBS services, that they have completed a provider survey and that they are in compliance with the standards. So examples of some of the different types of surveys that are having to be completed right now. There are some providers that were initially identified as being in heightened scrutiny, and those were providers that the state was going to handle all the follow-up work with that. The state began to do a closer review of survey responses and found that there were probably a little bit of lack of clarity in responses that providers provided. These surveys were done back in 2014, so several years ago. So the providers, the state began to remove some of those providers off of heightened scrutiny. So with that being done, there is some survey work that has to happen at the local level to ensure that the, any other elements that are required for HCBS, that those providers are meeting those, HCBS requirements as well. So meaning that persons aren't receiving services that isolate them from the community, that they have an opportunity to go out into the community to get things like haircuts, visit the doctor, and that everything doesn't happen in one setting. Other survey activity that's happening right now is there were some providers that did not respond. So we're having to work with those providers to directly connect with them to have them complete a survey to ensure that they are going to meet the deadline for being in compliance. And then there's also providers that were brought on board after October of 2017. In October of 2017, the state issued a mandate basically that said you can't bring any new providers on board unless you've done a provisional survey to ensure that they are in compliance with HCBS. So those providers didn't have an opportunity to complete a survey. So those providers recently got that opportunity to complete a survey to ensure that they can meet the HCBS standards. So there's lots of activity going on with that right now. Next slide, please.
Thank you. I've got a couple of questions. One has to do with credentialing. So after you do the ADA providers, is there a plan for who's going to come after that? And this is using that credentialing tool that we're looking at, right?
Right. Well, we wanted to start with SUD and ABA because they, some of the SUD and ABA providers weren't as far along in the continuum as our core providers were. That is, not something that's out of the realm of what could potentially happen, but we want to get through this pilot first.
Okay. Are we going to look at other groups that potentially might be, I just forgot the term, Medicaid sanctioned, if you will, where they are sanctioned and they should not be providing services? Do we ever look at those, or do we wait on the state for that?
Oh, no, we look at, we check for sanctions monthly for all of our providers and the practitioners. We do monthly checks for that. MedVercent will also do that as part of their work.
Okay. The other question I had has to do with HCBS, and I know that there was the push a couple of years ago, then it got delayed by the state for rolling it out. What is the time frame now for all providers that are going through this compliance and survey to adhere to an improvement plan to make sure they pass the survey, or to make sure that they're up to snuff?
So the state's plan for all providers to provide evidence of being in compliance is September of this year, so that if a provider isn't, then transition planning would need to occur because a provider can't receive Medicaid funding if they don't meet the HCBS standards. So there is a lot of activity going on right now to make sure that happens.
With us being the second largest county, more than likely in the HCBS space as well, for providers, how many of our providers are at risk for missing that September date? Roughly.
The last update from the state, the lists are not current. So those lists need to be updated, and that's something that's pushed at like every leads meeting. So we don't have a current list of the providers because the state hasn't published it yet. So we're pushing to try to get that because we do want to be able to work with our providers to make sure no one's at risk. But we also don't want to, we want to ensure that our network is complying with HCBS and nobody's isolated from being involved in the community also.
Right, we don't want to have to suspend anyone if we don't have to.
No.
Okay, that was it on my questions.
Are there any other questions from the board?
Okay, this next slide just talks about some of our activity that pertains to member experience. Our Community Evaluation and Education Committee is a committee that the membership consists of individuals served. It's been in existence for many years. We're proud to say that we continue our recruitment efforts, and we've expanded membership. At one time, I think there were only like 4 or 5 individuals. We have a bit more now, but we are always looking for more. That group meets every other month. The committee has provided input on our policies. They review our outcomes report. They're going to get a report on our QAPIP. They provide feedback on member experience. So it's a very valued committee because folks there are very forthcoming about and very candid in expressing their opinions. In terms of member satisfaction, staff from Quality provided an update to the board in November on the ECHO and our access services survey that MSET does. And we will do that on and continue to do that on an annual basis. MSET continues to survey people quarterly, so annually we provide an aggregate report on the outcomes from what MSET has seen. New this year for MSET is a telemedicine survey that they began to administer to individuals served. And the purpose is to really find out what the person served's opinion is about receiving services through telemedicine, because we know a lot of services have flipped to that recently. So the typical questions that are asked in our survey is, was it your decision to have a telemedicine appointment instead of an in-person appointment? Another question is, the healthcare provider I saw over telemedicine explained things in a way I could understand. The telemedicine visit was as good as an in-person visit. And overall, how satisfied were you with this telemedicine visit? And if you could have improved one thing about your telemedicine visit experience, what would it be? So we are just beginning to really get some data on that, so I don't have anything to report on what the voice of the person served is really saying at this point, but we will be able to do that in the near future. And let's see. I believe we can move on to the next slide. So at the board meeting, we will be requesting approval of our QAPIP for FY22, and we are open for any questions that you may have right now.
Are there any other questions for the quality team? I had one about the Consumer Evaluation Committee. That, when you say our committees, these are committees that are run by OCHN?
Those are committees. The CEEC is a committee that we facilitate, but the chairperson is the person served. But we're basically there to provide admin support.
And you had mentioned that you were looking for additional members. How are people notified or recruited?
The members basically recruit, and they speak on it at committee meetings at their core provider agencies. And I think we also mentioned, the CEEC reports to the CAC, so we also talk about it there.
Okay, thank you. If there's no other questions, because this is an item that we'll be voting on at the board meeting next Tuesday.
Ms. Newman, can you have your committee vote for recommendation for board approval?
Oh, this is our turn to do this. Okay. I'd like to entertain, to have a motion to, move this item forward for board approval at the board meeting.
So move. Steve.
Okay. All right, thank you. It's been moved by Dr. Taub. Is there support?
I'll support.
Thank you, Ms. Root. Do we need a roll call?
Just your committee needs to.
Okay. All
Do you
those
need
in-
to, you want me to let you know who's on the committee?
I'm sorry.
We can do a roll call if you want, because I have the committee list in front of me, just so in case anybody's,
Well, I would prefer a roll call.
okay, we can
Thank
do
you.
that. Dr. Hans? You just walked in. It's for the clap pit. Right. Ms. Root? Yes. Dr. Taub?
Yes.
And Ms. Newman?
Yes,
Okay.
thank you. Thank you.
Okay, thank you.
Next up, we have Ms. Burke coming with our assessment, needs assessment.
Good evening. I'm Frances Carley. I'm the Deputy Director of Strategic Initiatives. I'm here with Christine Burke, the Director of Communications and Outreach, and we'd like to thank you for the opportunity to present the Needs Assessment Survey to the board this evening. We're presenting the Needs Assessment as really the first step in the strategic planning process. Currently, OCHN has a strategic plan in place going from FY18 through FY22, and so now we're in the process of starting to develop the plan for the next few years through FY25. So the results from the Needs Assessment Survey and the feedback that we get from the community, from other stakeholders, the board, providers, this will form the building blocks for the new strategic plan going forward. So to start, through the Needs Assessment Survey, we're going to gather information from persons served, their families, and other stakeholders to set the organization's priorities for the next few years. And the first step in the needs assessment, we already gathered feedback from staff to develop and revise the survey questions from the previous cycle. And so we made a few updates, made some minor revisions, made some more substantial revisions, and for the more substantial updates, we added a few new sections, really focusing on prioritizing children and families, the children's crisis services, school mental health. That was one of the more significant changes. And then we divided out the sections to have a section for providers, a section for the board, and the reason for that was really to streamline the questions and streamline the sections so that the number of questions were more manageable and hopefully would improve the response rate. So this is the slide for the timeline for the strategic planning process, starting with the needs assessment. The needs assessment milestones are in yellow, and the other strategic planning milestones are in green. So this takes us through the fall, early fall, for completing the process. And so the survey currently is available to the board on Boardable. Our next steps are to incorporate feedback from the board and then finalize the survey to begin the data collection process. And so we have some in-person visits already scheduled, and we're planning to get that started in March. And we'll be back in April to present the findings and the results from the needs assessment to the board. And then from there, we'll develop an outline for the strategic plan, which we will then present in May, and using the results from the needs assessment as the foundation for that. And Christine will talk a little bit more about the outreach.
Hello, everyone. As Francis mentioned, the first steps for the needs assessment was we had all of our leadership, IT, our IOPS team look and offer suggestions. We took in consideration from the annual plan needs assessment that we just did last spring, some of the recommendations we had from people we serve. And then, of course, one of the last steps was making sure that we had input from board. I know the last meeting Malkaya mentioned about asking people what they want to hear during the board meeting, so we did add that selection. And then our plan is once it's approved by the board, we'll take it, the next day is always the CAC meeting. So we'll take it to them for input, final input before we start distribution, just to make sure that everybody's goals and ideas align. One of the first things we will do, the Oakland County Health Division is always very gracious in distributing our surveys and this information throughout the county. It's, over 100,000 people belong to their list. We will share the survey on our list. So some of those members include our faith-based community, hospital, other community members, persons served, of course, and families, our local and county elected officials, staff and network staff, OCHN staff and network staff, and of course schools. And we'll post it on our social media repeatedly throughout the term when we're trying to gather information. Sheila. She's running it today. We do, as Francis mentioned, we already have presentations scheduled, so some of the work groups that Marquita was talking about, we will be face-to-face with them. We have presentations scheduled for our clubhouses, drop-in centers, and I know I've said this before, we'll give the surveys during those visits, but we will really sit down and have those one-on-one conversations and important dialogues and take notes. I think sometimes there's information you can glean from conversations with people that you just can't capture in a survey, but we will incorporate all of that information in our findings as well. Other plans we have, so we will post, as I mentioned, the survey on our social media sites. We will send out a press release, and we'll ask the Oakland Press and the local community newspapers to let people know where they can find the survey on our website. We always distribute hard copies to all of our service sites. We'll have the opportunity, again, which we didn't last year, where we'll give hard copies in our provider lobbies, and then we'll just collect them at the end of the time. We have already notified my counterparts at our core providers. They'll share it electronically. They'll put it in their newsletter. We'll put it in our newsletter. That newsletter goes to 16,000 people. And then also we'll be, thankfully, we'll be starting to attend community events again. Dana just sent me one. So when we are at those community events where we're passing out resources and information, we'll keep hard copies of the survey, but we can also put a QR code on those surveys so that people can scan it and then they can go right to our website. And again, we will distribute the survey on Boardable, and the board will have its own section and area in which to answer any of the questions. I'm looking right at you, Jonathan.
Thank you. Thank you, Chair. So I do have a few questions regarding survey period, about some of the wording and some of the questions, navigation as well. So once it's been baked and it's ready for distribution, what is the survey period? Is it roughly mid-March to mid-April?
We will probably start distributing it at the end of February and go through April. Yeah. So the only reason we are holding right now is we wanted the board to have opportunity to view and offer some input, and then again, ask the CAC members because they encompass and really reflect our network because of the representation from our different core providers. We just didn't want to start distributing it until multiple eyes were on it and we had good input and thought.
Okay, thank you. The other question was about navigation, and I look at all the questions, and there's 49 of them. And the first ones are about people's, they are specifically for persons being served, and then our board and some others. So it always, and this is a question that's come up in the past, and I don't know if it changes this year, but there are some people that are persons served or their family members and their board members. Which questions would those persons see?
We tell people to select the option that they most identify with. And so, people can take it multiple times. We do not limit it one time. So we could make that suggestion if you want to take it from the perspective of a family member, if you want to take it from the perspective of a person served. I don't think there would be an issue with that. And then, of course, what you're looking at, we really can't start branching until all the content is approved. It takes a while to branch, and if you change one question, it changes the order of the branching for the entire survey. So that's one of the reasons what you see is a very long list, but people taking the survey will not. They will be directed right to their section.
So if they identify with more than one of those areas, they'd be encouraged to take the survey more than once.
Yeah, we could ask them to, we can include that in there and tell them to identify in which spot. I had not thought about that. That's a great suggestion.
Okay. The other one, and this is probably coming from Hadass, because I talked to her there before the meeting, but there are some questions that are, like, for instance, with persons served, there's one question, number 10, that talks about transportation for physical or mental health services, but then for family, it's two different questions, 22 and 23, for transportation, instead of the same question, but from I'm going to get the person from first person versus second person, if you will, from persons served versus family member.
So one of the reasons we worked with the transportation team to develop those questions, they're looking for very specific data. You'll see multiple questions that are similar and worded just a little bit differently, and when we go back to look at the data, we're trying to see if what the people we serve are asking for, if it aligns with the perceptions of their family members and their allies as well. So we do have some questions, if you look at them and think, boy, they're very similar, one's just worded a little differently. We do that intentionally to make sure things are aligning. Some of that we do with our providers as well, so that if the people we serve answer, we're asking questions in a certain way to see, do the providers also agree? I think, for one example I could give during the annual survey last year was for direct support professionals. And we had a really good response from people we served saying they had really good relationships with the direct support professionals. When we looked at the data from the family, we saw the same response. And that's what we hope to see. What we don't want to see is one response from people we serve and another response from the people around them.
Right. I was just pointing out that for the person served, there's one question there that covers both physical care and mental health care. But when you get to families support, there's actually two questions, one for one area, one for the other.
Yeah,
it would seem that you'd want to capture it the same way.
I'll check with the transportation committee about, I know we had a conversation about where we're doing that. And we were also trying to minimize the questions for the people we serve. Last year was the first time I personally was going out to do those face-to-face interviews with people, and it was very obvious to me immediately that it was overwhelming. And so you will see some sections where we're going to ask maybe multiple questions where we're not going to ask the people we serve because they got frustrated and they didn't want to complete the survey. We don't want that to happen. But I'll double check that too.
So two more questions from points that I saw. Question number 13. It's with your transportation provided. And it might be.
It says you. I think it needs to be changed.
To the transportation it's provided.
Yeah.
Yep. And then the last question is, I know we've got all kinds of demographics questions, but we don't have any questions that are geographically related, like what part of the county do they live in, like north, east, south, or west, or are they in urban, suburban, or rural, just to see if the responses are different in terms of needs of care.
Let me check with IT. I think if we did something that we asked people to provide a zip code, it's not necessarily an address, and then we can do some geographic information
geocoding
gleaned
for
from
that.
that. Yeah, I know there are a number of applications where you type in a zip code and it'll map it for you instantly. So we can definitely
can
make
do
that addition. I appreciate that.
All right. Well, those were the questions I had. I'm sure there's other questions.
Collins?
Thank you. So a couple questions. The first one is kind of a structural question in this. So I noticed that, and I apologize if this got asked already, but in the section on families, allies, and supporters, there's not a section like there is for everybody else that is kind of like a catch-all. What ideas do you have for priorities? Kind of more of a narrative. That there isn't that section for families and allies and supporters, but there is for the other groups. Can you change that so we can hear from people about that? The questions seem to be very segmented, and families, allies, and supporters of those using services, I think, would have more things to add than just answer 7 questions.
So you mean instead of the check boxes we have for
Yes.
those lists?
There's no narrative section, and there is for the other groups.
Yeah, we actually made some modifications to this where we've been tweaking it as we go along, and we can
Okay.
change it back where we just put the narrative at the bottom, because it does look very long to you right now looking at it, but traditionally, say you were answering it, you might answer 6 questions and then get right to the narrative. So,
Right. But I'm assuming that, are you sending the entire survey to everybody? Or does it get segmented to, so families, supporters, and allies get that section?
they all get this, everyone gets the same survey, but when you select, identify yourself, it's branched or rerouted to your specific section.
Okay, so yeah, we will need that added because...
You want the narrative in each?
Yes, absolutely.
Okay.
Because I'm gonna tell you right now, when the information comes back, I really wanna know what the families, supporters, and allies are saying, because, you know, I'm coming from the special needs area, but I'm sure with all the service areas, the families, allies, and supporters have, I think, very important suggestions and observations to make to us, because many times the users of the services, in many instances in the special needs community, they're not able to verbalize that. And in other areas, people who are under treatment may not be able to adequately verbalize, so they need some assistance. So I'm very interested in what the families, allies, and supporters have to say to us.
Yeah, we can put that back in there. I think one of the reasons we removed it, but I understand completely, is that when you see it branched, it might look like you answer your questions, you'll see a narrative, you'll answer some more questions, and then there's a narrative at the end of the survey again. So it may look duplicative, but it's not a problem. And they may answer something in the first section that they don't answer in the second, so we can definitely do that.
All right, thank you very much.
Yeah, no problem, I appreciate that.
Are there any other questions?
Thank you.
Thank you.
I'm sorry, next we have, I'm still getting used to this. Next we have the quarterly team update.
Hi,
with
this is Jill.
Jillian.
Hi, can you hear me?
Yes, we can hear you.
Okay. Good evening. I'm Jillian Trumbull. I'm the director of the Provider Network here at Oakland Community Health Network, and I am going to present on the first quarterly update for the Provider Network team. Next slide, please. This evening, I'm going to give an update on 2 of our initiatives. One is the Direct Support Professional, or DSP, wage pilot, and the other is our Applied Behavioral Analysis, or ABA, request for proposal. Next slide, please. Okay. First, I'm going to give an update on our DSP wage proposal, or I'm sorry, wage pilot. This is in our annual plan in the budget and finance section. And the reason is we're implementing this wage pilot to assess the impact of increased wages on staff shortages and outcomes to people served. I think it's no surprise to this board and to many members of the community that there is a staffing shortage throughout the state of Michigan and really nationwide. So a big part of the reason for this pilot is to see if increased wages help with retention, recruitment, and outcomes to people served. It is a limited pilot. It is scheduled to last 6 months and hopefully or possibly up to 1 year during fiscal year 22. The impact is provider network stability, and we are in process in the pilot. Next slide, please. So the wage pilot officially began on December 1st, and that was following an application process. Specialized residential service providers in our network were invited to apply to be part of the wage pilot. And from those that applied, a selection committee reviewed the applications and selected providers that met the identified criteria. The pilot will last at least 6 months, as I said, and up to 1 year. There are 5 providers in the pilot representing 11 homes. And it was important to us to select providers that represent all populations of people served. So we have providers that particularly support individuals with intellectual and developmental disabilities. We also have homes that are focused on supporting people with mental illness. We have homes that are barrier-free and focused on complex medical needs, as well as homes that focus on complex behavioral needs. We also were sure to select from each quadrant of the county. So we have homes representing northern, southern, eastern, and western Oakland County. We did pay particular focus to northern Oakland County because that is historically our hardest to staff area in the community. And during the pilot phase, direct support professionals working at the selected homes are paid a wage of $18 per hour. There is a higher wage for those in supervisory positions, but the DSP starting wage is $18 per hour for the duration of the pilot. Next slide, please. And as I mentioned earlier, these are some of the goals of the pilot. We really want to look at the impact of staff recruitment and retention and the impact on use of overtime. Our hope is what we will see is with the increased wage, providers are able to more easily recruit staff, they are able to retain staff, and then they're able to reduce their use of overtime. And then hopefully what that will show us is there's either cost neutrality or cost savings in having a higher starting wage. At this point, it's too early in the pilot to tell if our outcome or our hope is going to come to fruition, but that's one of or some of the goals there. Also, we have want to assess the impact on calls for emergency services. So do we see a reduction, for example, in calls to 911 or use of common ground and need for psychiatric evaluation? Do we see an impact on incident reports and or recipient rights investigations? So those are the main areas we're looking to assess. The providers who are participating are submitting monthly reports to OCHN, and we will use the data that they're submitting to analyze the outcome of the pilot. Next slide, please. I believe it's questions. Are there any questions on the direct support professional pilot before I move on to my next item?
I had a question.
Sure.
Thank you. The increase, it's $18 an hour, you indicated for the pilot. How much of an increase is it from the original wage?
So I'm gonna take it. I'm gonna speak to this, and then Anya Lyson will correct me if I'm wrong here. We have with this past fiscal year, we were able to increase our wage across the board to $15 per hour, and that was a result of the $1 an hour wage increase that the OCHN board approved, as well as the $2.35 increase that was approved by the legislature. So we're paying to our providers a wage of $15 per hour for their direct support professionals.
Was that your only question?
Did that
I'm
answer the
sorry,
question?
Jillian, I had a hard time hearing you on the end. How much did you say per hour?
It's $15 an hour as of the beginning of this fiscal year. And that was the result of the wage increase that the board passed and the legislatively mandated increase.
Hello.
Hi. I just came up just to help clarify for Jillian. She has it correct. We did up all of the base wages to $15 an hour, which is inclusive of all of the direct care wage pass-through and enhanced compensation that has been pushed out through the department. That also includes adjustments to both the supervisor and manager wages that are in our rate structure as well. So the $18 an hour would represent a $3 increase above and beyond the $15, and then each of them is incrementally changed based on those percentages.
Are there any other questions for either Jillian or Anya? Dr. Hines?
Yeah, my question is about what is, refresh my memory, maybe I missed it. What is the duration of this pilot? And is there any requirement for training before they are enrolled in this pilot? For example, in a lot of the homes, there is turnover of staff, and there are a lot of new staff that come in who have a certain period to complete their training. How does that impact this pilot?
So the pilot is scheduled to last for at least 6 months. We're hoping to be able to have the pilot last for 1 year. It began December 1st, so it's really new still. We're getting our first month of reports. In terms of staff training, the training requirements are the same as for any other staff before they start working. So the providers who were selected, the homes that were selected are using a core set of staff, some who may have already been employed with the organization, some who may be new to the organization, and they're required to meet all of the same training requirements that they would be before they provide services. I do think I skipped one of your questions. Did I miss one of them, Dr. Hans?
Yes, thank you.
Are there any other questions for Jillian or Anya?
I have one. You said that it's, sorry, this is Rena. You said that it is slated to be 6 months with the hope that it'll go for a full year. What are the criteria that need to be met for it to then be able to be extended for the full year?
So again, I'm hoping not to have to defer to Anya on that, but she's nearby if I misspeak. The board appropriated $500,000 or approved $500,000 for the pilot, and the length of the pilot being at least 6 months, and hopefully a year will really be dependent on the funding from the pilot that's been utilized.
So yeah, it was entirely budget-based. We just wanted to make sure we had the funding to extend it. Ideally, we would do it for at least a year, just to really get a good data set to compare to other situations.
Any other questions?
I just had one other comment. It's John Paul. So at the end, when we assess if there are any changes in staff or retention, just kind of my thought was that I was just reading an article today in the Detroit Free Press, I think it was, about the governor doing something similar in the schools with regard to bonuses for retention purposes. But there were some good ideas in there, and I think it just came out today, and I just briefly read it, but because that's where there's been a big struggle as well with staff and teachers and things like that. But speaking to like bonuses if you stay for a certain period of time. So if you stay for a year, then you get a $2,000 bonus, like one lump sum type thing. So hopefully the results are showing some effectiveness once this is all done. But maybe if it's not, maybe then rather than scrapping it or something, we could look at potentially adding something additional that could help. But it was just made me think because reading what they were initiating in the schools that came out today within the governor's office. Thank you.
Yeah, thank you. We are certainly open to any suggestions and also considering alternatives as we move forward.
I had a couple questions, Jillian. You might have said already, but how long has the pilot already been going on?
It only started on December 1st, so we don't have any data to share with the board at this point that would show any outcome one way or the other.
Okay, and my last question is, once the time period is up, then what's going to happen?
So at that point, we will look at the outcome of the pilot and we will make some decisions about what can be, if anything, can be continued indefinitely. All of the providers who applied and who agreed to be part of the pilot are aware, as are their staff, that this is a time-limited pilot. And if it's not something that can be implemented system-wide, then their rate structure would go back to the rate structure that is standard across our entire network. But certainly our hope is the outcomes show that it's either cost neutral or minimal cost or even cost savings to apply system-wide.
Thank you.
Sure.
No, any other questions for Jillian or Anya? Thank you, ladies.
Sure. I was really hoping to keep Anya from having to answer questions, but always I get stumped when we get to the finance ones.
At least you have somebody to fall back on. So
absolutely, right? And the
not a
next
problem.
item for my update is the Applied Behavioral Analysis Request for Proposal, and that is in the annual plan goal of ongoing network stability. The reasons, the what and the why, is increasing our network of ABA providers with the goal of adding capacity for service provision. This has been done via an RFP, or request for proposal process, during this current fiscal year. The impact is provider network capacity, and the completion status is in process, but nearing completion. Next slide, please. This slide shows an overview of our ABA numbers as of January 25th. They always fluctuate a little bit, but as of January 25th, there were 407 individuals enrolled in the ABA benefit. And 114 individuals on the waiting list. So the waiting list includes people who are waiting for a specific provider, as well as individuals who may be in services but are looking to change providers. So the 114 isn't necessarily an exact number, but it is a very close and very accurate reflection of what we're seeing in terms of people who are waiting to get into an ABA provider. It is consistent with what we see across the state. Every area of the state does have a wait list for ABA services, and the struggles, the capacity struggles, seem to be the same, that there are the shortages of behavior technicians, and really those after school and weekend hours are in high demand for children and youth ages 7 up to their 21st birthday. So we do see that I think it's 69% of the individuals on the wait list are 7 plus. So you will see the breakdown by core provider, providing services over to the right in the chart there. We really wanted to try to make some effort to increase our capacity and reduce or eliminate the wait list altogether. So what we've done is we issued an RFP to ABA providers. There are 12 existing ABA providers in our network. We did not ask those providers to rebid. They were all in good standing, so they remained providers in the network. And the bid was simply, the RFP was simply to add new ABA providers who met qualifying criteria. So from that RFP, the committee was able to identify 10 providers to be added to our network. And we are in the process of finalizing everything that's needed to add providers to the network right now. One of the requirements was providers had to commit to being able to serve individuals ages 7 up through their 21st birthday. They had to commit to having regular evening and weekend business hours and to assist us in removing individuals from the wait list and into services. So we have done the general provider onboarding with all 10 providers. The contract credentialing and privileging process is complete for most of the providers. There's a couple who are still in process. And as the contracts are being executed, our team is meeting with the ABA providers individually to onboard and add them to the network. So we do expect this to be closed or to be completed within the next several weeks, and we will have added 10 more providers to the network. We will certainly use that to assess, or we will look at assessing how this has impacted our wait list, if it impacts our wait list, and if there are any other strategies we might need to consider for increasing capacity for ABA services. Next slide, please. For both items that I presented on, the fund source is Medicaid. As I mentioned, and as Anya mentioned, the board did approve $500,000 for the direct support professional pilot for fiscal year 22. And then for the ABA bid, there's no increased costs to the board, or that the board would need to approve. It's built into the service budget. I believe my next slide is questions.
Ms. Root?
Thank you. So the 10 providers, those are 10 separate agencies, correct?
Yes.
Okay. So that's great that there's no increased cost, but I was just wondering, are there any other challenges we should expect for our capacity to add 10 agencies at one time?
There are certainly going to be some administrative challenges within the organization, which we have a plan for managing and monitoring, just in terms of the amount of administrative work that the department requires for the benefit, and making sure that we're able, that we're maintaining all of the documentation requirements for management of that benefit. The other thing we really need to watch to assess how capacity is impacted, or if it's impacted, is the behavior technician shortages. What we don't want to run into is a situation where, a behavior techs are resigning from one organization and hopping to other and then another, and it's not really addressing the overall shortage of technicians. So I think that's probably the primary thing that we need to pay attention to, and make sure that, come up with ways to address that shortage. And again, that is not an Oakland County specific issue. That is a statewide issue, probably a nationwide issue. But we really need to make sure that there are enough behavior technicians to manage all of the need.
Thank you.
Mm-hmm.
Are there any other questions? Thank you, Ms. Jillian.
Thank you.
It confused me too. I thought, did we pass me? I just want to give you a brief update about our outreach and awareness efforts for February. There's some of March in here. We're starting to get into that pattern where we will be able to report more on the upcoming month as things start to schedule. First, I wanted to touch base with Oxford Schools. Our clinicians continue to be on site as requested. I know Dr. Taub had asked some questions about the numbers of individuals we have seen. That number is now 1,700. 1,250 people have been counseled on an individual basis, and then 450 in a group setting. Also, our leadership, I only attended one. Dana might want to touch on this at some point or another business, has been meeting with the Department of Justice for their Victims Assistance Division in terms of what they will be doing when they come into the county or to the community for support. I will say I shared with Dana this morning and some other members of our leadership that on Saturday, one of the superintendents sent a video of a high school basketball game, and it was very emotional but wonderful to see the young adults being young adults having fun. And I said to her earlier, I was so grateful for everybody, but Adam popped in my mind right away because he has been just so stellar on site from a clinical perspective there every day. And I did thank Dana. There was an early on opportunity when we had to discuss what our approach was, and Dana was very much present, but just smiled and said, do your job, and empowered everybody to move quickly and make decisions when they needed to be made. And I think that was essential for us to be responsive. So I thanked her this morning, but I think everyone else should know that she took that stance, and it was very effective in the way we responded to Oxford's requests. We had a busy media week. So Dana was interviewed by Paula Tutman on Channel 4. That did air regarding suicide awareness. She also interviewed with Mark Cavett. He's doing a story about privatization and advocacy. I expect that story to run later this week. He also interviewed two individuals whom we support to get their perspective on the legislation. She interviewed with Carol Thompson regarding mental health supports for children in juvenile facilities. Primarily in our role, it's how do we help them successfully transition back to the community. Senator Gary Peters is going to be at Common Ground. She'll be touring with him and with Heather Ray. We are in the process of recruiting people to participate in an advocacy video. The association created a video a few months ago. We were a little concerned about the lack of diversity. We asked if we could participate in recruiting people for that purpose. So we are partnering with Detroit Wayne. Each one of us is recruiting 10 to 15 people. We will be having people who will be reading the script using sign language. They'll be saying it in Spanish, Arabic, and Chinese. So very excited about this opportunity. So we had a contract with the program Mind Matters. It's actually a sponsorship. It's a relatively small sponsorship for the amount of media coverage that we will get. Dana will be doing an interview and taping for that on February 26th. I'll make sure that the board receives copies of that information. She is also serving on a panel for, it's also called Mind Manners event that we were asked to participate in from Cmha, and we'll make sure that you have the link. The link is in your presentation and in Boardable, but we'll send you another one. Our Virtual Abilities Awareness event is March 8th. Suzanne is leading that effort for our organization. We are really hoping to get back to being in person soon. Our last in-person event was 2 years ago in March, and it was that event, and I think we had about 140 people in the building. So maybe next year. February, we'll be hosting vaccination education outreach efforts within our SUD residential settings. That is part of a launch. Starting in March, we will actually be hosting clinics 2 to 3 days a week. We did receive some funding, grant funding from the state for this initiative because we early on saw that there was a significant difference between the individuals we serve who have mental health challenges or developmental disabilities who are vaccinated and those who have substance use disorder. So this is just an attempt to ensure that those who want to be vaccinated have the opportunity and the resources and the information. And we are also participating in the association's call for art. We have a traveling art show in the state when we don't have a pandemic, but we put a call out once a year, or every 2 years, I take that back, and then Oakland County is allowed to submit 2 art pieces from people we serve. We ended up getting 15 pieces of art submitted. The way we select a winner is we take pictures, we let our staff choose the top two, and then traditionally what we've done for the last couple of years is we purchase the art that is not selected if the individuals does allow us, and then we display it in the building in different areas. So we're excited about that. And finally, in regard to schools, I know in the past I've talked about the virtual school presentations we've been doing with MORC and with our core providers. They are getting ready to schedule those presentations again for the spring. The last two we did were in Farmington Hills and in Novi. And additionally, Mr. Bernard had received a newsletter from Farmington Schools where their DECA group has chosen substance use and mental health awareness as its mission. The DECA groups choose a mission. Every high school has one. So he encouraged us to get in contact with them and then see if there's any way that we can support these young adults in their efforts. That's what I have for you tonight. Any questions?
Doesn't look like it.
Okay. Thanks, everyone.
This is our second opportunity for public comment. Do we have any public comment for this?
There is no additional public comment in the online forum or in the chat, but we do have an opportunity for public comment at our board meeting next week.
Okay, thank you.
You're welcome.
Now it's time for board member comments. Ms. Sheila, can you call the roll, please?
Dr. Hans?
Well, I'm sorry, I was a little late, some transportation issues with my son. Whatever I heard, very encouraging, especially the community outreach. It's heartening to see the support that we have provided and the context that we are establishing within the community, because I believe it takes all of us. It's a cliche, it takes a village, but that is indeed true. So thank you for all your work and all the presentations.
Mr. Furman?
Yes, and I just, again, want to echo what was said just a minute ago. I love how how we close each committee, the whole meeting, with the community awareness piece of everything that's going on, and not only the things that have gone on recently, but the things that are going on, because I think it encourages both us as board members and the community at large to participate if they're either watching this meeting in person or looking at it online. So that, and I again want to thank all members of the staff that took the time to put together the presentations tonight, whether it be on the survey or on the QuaTib or the presentation from the Service Network team. So thank you very much and have a good night.
Mr. Torres?
I just wanted to remind everybody we have bylaws committee meetings coming up. If any board members are interested in watching or participating as public, the next one will be on February 10th, then 17th of February, and then March 9th and March 16th from 5:30 to 7:30 p.m. Thank you.
Ms. Naomi Dyer?
Yes, I just wanted to kind of echo what's been said. Really nice to hear about all the different community outreach events going on. I'm really excited, and it's really cool to see how many things are happening. Also really looking forward to seeing how the wage increase, how that goes, and I'm very excited about the fact that 10 new ABA providers are being added. As a ABA provider myself, not with OCHN, but in general, I know the struggle, so I have my own wait list as well. So I'm looking forward to getting those kids off that list and seeing how that goes. So thank you, everyone.
Dr. Todd?
I know it's repeating it, but thank everybody for all the time they spent on preparing the presentations.
Mr. Cowan?
Thank you. First, I'm glad the Oakland County Board of Commissioners has sent us another board member, and hope we still have one opening, so hopefully we've had some applications that they can consider and fill that final spot. Secondly, it struck me tonight that the little interconnection between some of the things we discussed. So we have the needs assessment, and we also have the pilot program for workers. So it seems to me, in an increase in wages, I very much think we're going to see in the needs assessment from the families and the users just like getting back to normal, because we have so many issues in employment in the areas of transportation, the work programs, all those have been cut back because of COVID and the lack of adequate staffing. Socialization, both in the private and public sector, for many of our consumers is virtually been eliminated during this time of COVID. So I think people are going to be looking for, back to a return to normalcy, whatever the new normal may be. But at the core of this is going to be the staffing. And I'm glad we're tackling that problem, but that is going to be, I believe, the major problem we have in some areas is the staffing of our group homes and many other facilities, because people are, have left the workforce. We don't have an explanation for it, but it's here, so that's our challenge. And I think we're going to see a lot of that in the needs assessment. Thank you.
Ms. Root?
I don't have any additional comments. Thank you.
Mr. Lanson?
Thank you. And I'll use the old term ditto for what Adam said about staff in their presentations and materials and communications that's going on. We are getting back to normalization, and there are new events going on. So tomorrow and Wednesday is the virtual winter conference for the Cmha, and I know Mel Kai and I both are registered to attend that, so I'll have a report on some of the things that I found interesting. But because it's virtual, that means that the traditional Tuesday morning meeting that we would have at the conference isn't going to happen. Instead, you're going to see an email that goes out to the board members, at least, that Tuesday, February 22nd, between 10 and 11, we will have a meeting invite for that metro meeting, regional meeting. Just so look at it, and hopefully you'll be able to attend that. That's it for me.
Ms. Newman?
I just want to echo what everyone else has said. Thank you so much for all the presentations that were done, and it is really, really encouraging that that we're making a difference and people can see it. So thank you, and with that, entertain adjournment.
Can we have a motion?
I need a motion.
I'll make that motion that we adjourn.
Do we need a second?
Support? It's Adam.
It's been moved in second, so we don't have to vote on that. Okay, the meeting is adjourned. Thank you.